Welcome to the Deep Dive. Grab your favorite beverage, because we're about to plunge into a stack of sources to pull out the essential knowledge, just for you. Today, we're looking at a condition called hydrocephalus, and, well, the pretty complex world of treating it with surgical shunts.
Yeah, we've got some really interesting material here. It covers the basics, what hydrocephalus is, how the main treatment works, these cerebrospinal fluid or CSF diversion shunts, and maybe most importantly, the surprisingly wide range of complications that can actually come along with them.
That's right. So fundamentally, hydrocephalus is about a problem with how that crucial fluid, CSF, flows around and inside the brain. And while shunts can be absolute lifesavers, the story doesn't just stop after the surgery.
Not at all. It's a challenge medicine has been grappling with for a long, long time. Our sources even mention Hippocrates way back when, trying to figure out fluid buildup in the head. Rudimentary stuff, of course.
Wow, Hippocrates. And it took until, what, about 100 years ago for effective diversion methods?
Pretty much. And even then, it's been this constant process of refinement. Like we saw this figure, by 2014, there were over 127 different shunt designs out there.
127.
Yeah.
That tells you something, doesn't it?
It really does. It highlights how much hurt, how much trial and error goes into trying to get this right for patients.
Okay, so that's our mission for this deep dive. Unpack these sources, give you the core understanding of hydrocephalus and shunts, and then really focus in on this, well, intricate and sometimes unpredictable world of shunt complications. All right, let's start at the beginning. What exactly is hydrocephalus?
Okay, so simply put, it's the symptomatic buildup of cerebrospinal fluid, CSF, inside those fluid-filled spaces within the brain, the ventricles.
And why does that happen? You mentioned the CSF flow.
Right. And think of it like plumbing, maybe. CSF is mostly produced by these structures called choroid plexi. It flows through these connected channels, the ventricles, then it exits out into the space around the brain and spinal cord, the subarachnoid space, and finally gets absorbed back into the blood, into the veins.
Got it. So hydrocephalus is like a blockage in the pipes.
Yeah.
Or maybe the drain isn't working.
Exactly. That's pretty much it. Either the flow is obstructed somewhere, that's obstructive hydrocephalus, or the pathways are open, but the absorption mechanism isn't working right that's communicating hydrocephalus. There's also a rarer cause where the brain just makes too much CSF.
And you also hear about normal pressure hydrocephalus, NPH. Where does that fit in?
Yes, NPH. That's a type of communicating hydrocephalus, usually seen in older adults. The tricky thing is, the pressure, if you measure it at one point in time, might seem normal, but the dynamics, the way the fluid flows and gets absorbed over time, are actually off. And that leads to a very specific set of symptoms.
Okay. And who tends to get hydrocephalus? Our sources mentioned peaks.
Yeah, it typically shows up most often in two main groups. Infants, often due to issues they're born with, or sometimes bleeding in premature babies, and then again later in life, that's often the NPH type. But the actual numbers, the prevalence, can vary quite a bit depending on age and where you are globally.
So how do doctors figure out if someone has it?
It's usually a combination of things. What symptoms the person has, what the doctor finds during an exam, definitely brain imaging like MRI or CT scans, and sometimes they'll directly measure the pressure of the CSF.
That brings up a good point.
Right.
Why do the symptoms vary so much if it's just fluid buildup?
That's a great question. It really depends on a few key things. The patient's age is huge. A baby's skull bones aren't fused yet, so their head can expand, whereas an adult's skull can't.
Ah, right.
Also, what caused it, the underlying reason, where exactly the problem is located within that CSF pathway, and how fast it all happened. Did the pressure build up gradually or really quickly?
Okay, so for infants with that expandable skull, what might you see?
You might notice their head growing really fast or just being unusually large. The soft spot on top, the fontanelle, might be bulging. You could see vomiting, problems feeding. Maybe they're really sleepy or unusually irritable. There's that classic setting sun sign where the eyes seem to look downward all the time. Seizures can happen too, and developmental delays. Oh, and sometimes if you tap on the skull, you might hear this odd sound, like a cracked pot. They call it the Meeswan sign.
Wow. And for older kids and adults whose skulls can't expand.
Right, so the pressure builds up inside. That often leads to headaches. Sometimes neck pain, nausea, and vomiting are common. Drowsiness, irritability, confusion. Vision problems are a big one. Blurred vision, double vision, sometimes trouble looking outwards with their eyes. Balance problems, difficulty walking. People sometimes say their feet feel like they're stuck to the floor. And you can also see changes in personality, memory issues, and problems with bladder control.
And for NPH, that specific type in older adults, You mentioned a classic triad.
Yes, the Hakim triad. It's these three core symptoms: difficulty walking, gait disturbance, cognitive decline or dementia-like symptoms, and urinary incontinence. Finding those three together really points towards NPH.
And imaging is key for all of this, you said. MRI or CT.
Absolutely crucial. MRI is often the go-to because it gives such a clear picture of the brain structures, and you can sometimes even visualize the CSF flow itself. But CT scans are used a lot too. They're often faster, readily available, and really good for getting a quick look, especially if doctors are checking on a shunt that's already in place.
And it sounds like leaving this untreated is really not an option.
Definitely not. Untreated hydrocephalus can cause lasting brain damage and can even be fatal, so treatment is essential.
Which brings us back to the main treatment approach, surgery, right? To divert the fluid.
Correct. For most people, the standard treatment is surgical intervention to reroute that excess CSF.
And that usually means putting in a shunt system. Could you break down how that works?
Sure. Think of it as a sort of internal drainage system. There are three main parts. First, a catheter. A thin tube is placed into one of the ventricles inside the brain.
Okay.
Second, that tube connects to a valve. This is a really important piece because it controls how much fluid drains out, usually based on pressure. And third, there's another length of tubing, the distal catheter, that runs from the valve down to another part of the body where the CSF can just be absorbed naturally.
And where does it usually drain to?
The most common place by far is the abdominal cavity, the peritoneum. That's called a ventriculoperitoneal shunt, or VP shunt. It's especially useful in children because you can leave extra tubing coiled up in the abdomen to allow for growth, so you don't have to lengthen it as often.
Makes sense. Are there other places it can drain?
Yes, though less common. A ventriculoatrial, or VA shunt, drains into one of the chambers of the heart. A ventricular pleural shunt goes into the space around the lungs in the chest cavity. And sometimes, particularly for conditions like pseudotumor cerebri, they might use a lumboperitoneal shunt, which starts in the spinal fluid space in the lower back and drains to the abdomen.
Are there alternatives to putting in a whole shunt system?
There are, yeah. For certain types of obstructive hydrocephalus, a procedure called endoscopic third ventriculostomy, or ETV, might be an option. It uses a small camera and instruments to create a tiny hole within the brain itself, basically creating an internal bypass for the fluid to flow around the blockage. Less commonly, there's choroid plexus coagulation, which tries to actually reduce the amount of CSF being produced in the first place by treating those choroid plexus structures.
And what about emergencies if someone comes in with sudden, severe symptoms?
In acute situations, they might need temporary measures, like an external ventricular drain, or EVD, which drains the fluid out of the head into a collection bag outside the body. Or, in very young infants with an open fontanelle, sometimes a needle tap through the soft spot can provide quick, temporary relief.
Okay, so we've established shunts are often the go-to life-saving treatment. But here's where our sources really got interesting and maybe a bit concerning. These shunts can have problems.
They definitely can. And unfortunately, shunt complications aren't rare. The rate of malfunction, especially in the first year after surgery, is quite high. Our sources mention figures up to 50% malfunctioning within that first year. And the risk accumulates over time. One source suggested maybe up to 81% of patients might experience a failure within 12 years.
81% over 12 years. Wow. That really changes the perspective. Is it not a one-time fix for many people?
Not always, no. It often requires ongoing monitoring and sometimes further interventions.
And what are the most common reasons for these failures?
The two big ones are infection and obstruction.
Okay, let's take infection first. How common is that?
It's a significant risk, particularly for young infants, like under 6 months old. The sources suggested maybe around 25% in that age group might develop an infection. It's often caused by bacteria that normally live on the skin, like Staphylococcus epidermidis, getting introduced during the surgery itself.
Right, and obstruction. What causes the shunt to get blocked?
It can happen anywhere along the shunt pathway, the ventricular catheter, the valve, the distal tubing. Common culprits are things within the CSF itself, like high protein levels or blood from a hemorrhage, which can clog the narrow tubing. Infection can also lead to debris or inflammation that causes a blockage. And sometimes it's something really unexpected. One source detailed a case where a dead roundworm actually blocked the shunt and caused an infection.
A roundworm.
Seriously.
That's wild. So if a shunt gets blocked, what happens to the patient?
Well, the CSF can't drain properly anymore, so the pressure starts to build up again. The symptoms often look just like the original hydrocephalus coming back: headache, vomiting, drowsiness, vision changes, all that.
And fixing it usually means more surgery.
Almost always, yes. They need to figure out where the blockage is and revise the shunt, which usually involves replacing the blocked component. And because obstructions are relatively common, many patients unfortunately need multiple shunt revisions over their lifetime. The sources indicated something like 50 to 70% might need more than one revision surgery.
50 to 70% needing multiple surgeries. That really emphasizes the long-term management aspect. Okay, besides infection and obstruction, what's the next most common mechanical problem?
That would probably be disconnection or fracture of the shunt tubing.
Okay, so disconnection is where two pieces come apart, and fracture is an actual break in the tube.
Exactly. Disconnections typically happen at the connection points, like where the catheter meets the valve or the valve meets the distal tubing. Fractures are physical breaks in the material of the tubing itself. These can happen anywhere along the line, sometimes near where the shunt enters the skull, the burr hole site, or further down along the tubing's path under the skin.
What causes these breaks or disconnections?
Sometimes it might be related to how the shunt was secured during surgery. Maybe a ligature was too loose or too tight and damaged the tubing over time. Other times it can be due to mechanical stress, like strain on the tubing from movement, especially in growing children. The good news is that newer shunt designs, particularly those made as a single continuous piece rather than multiple components joined together, seem to have helped reduce the rate of disconnections.
The sources had pictures of this, right?
Yes, some really clear examples. One showed a noticeable gap, like 3.7 centimeters, between disconnected parts of the tubing. Another showed both ends separated right at the burr hole. And there was that striking image of a shunt catheter that had completely pulled out of the ventricle and was just coiled up in the subcutaneous tissue of a teenager's neck.
Pulled right out and coiled in the neck. Goodness. Okay, what else can go wrong?
Well, you can get fluid collections forming around the shunt system itself. If CSF leaks out near the entry point in the skull, it can create a soft swelling under the scalp called a CSF varix. Or fluid can collect along the subcutaneous path of the tubing, forming what's called a CS foma. The figures showed examples of these kinds of lumps.
And then there was migration. This sounds like the shunt itself moves around.
It does. The catheters aren't always stationary. You can get proximal migration, which is actually pretty rare, maybe 0.1 to 0.4% according to one source. That's where the ventricular end of the catheter gets pulled backwards into the skull, sometimes due to things like gnat movements causing a sort of windlass pulling effect or pressure changes.
But it can also just wander elsewhere.
Oh, yeah. The distal tubing, especially if there's some slack, can recoil or travel within the subcutaneous tissues. There was that fascinating example mentioned of a VP shunt catheter that somehow migrated all the way up into the chest wall and ended up coiled behind the patient's breast. And then you get the really unpredictable ones. The sources called them vagabond catheters.
Vagabond? That sounds ominous. Where do they end up?
Just about anywhere, it seems. These are the ones that can actually perforate or poke through internal organs, and they can even exit the body through completely unexpected routes. The sources documented cases where shunt tips have come out through the urethra, the vagina, the anus, even the mouth after perforating the stomach or bowel.
Out the mouth. Vagabond is putting it mildly. That's unbelievable. Can the shunt itself cause changes to the brain or skull over the long term?
Yes, definitely. Over time, you can see calcification, like calcium deposits, forming either inside the catheter or around it. This might be related to the silicone material breaking down very slowly. The skull bones themselves can sometimes thicken where the shunt passes through. There's also a condition mentioned, sometimes called armored brain, where this thickening is associated with old calcified blood collections under the skull surface. The shunting can also sometimes lead to the formation of new walls or compartments called septations or cysts within the ventricles, maybe triggered by prior bleeding or infection. And you can get scarring called gliosis in the brain tissue right along the path where the catheter sits. Rarely, shunting can even cause the cerebellum, the back part of the brain, to shift upwards.
And since these tubes drain into other body cavities, like the abdomen or chest, they can cause trouble there too.
Absolutely. With the less common ventriculopleural shunts draining to the chest, you can sometimes get fluid buildup around the lung called a pleural effusion or even a collapsed lung, a pneumothorax. Very rarely, the tube could even erode into an airway.
And for the much more common, VP shunts draining to the abdomen.
Abdominal complications are certainly more frequent. These can include things like the catheter tip poking through the diaphragm muscle. You can get free air in the abdomen called pneumoperitoneum, or the bowel can get blocked, often because it gets tangled in adhesions, which is scar tissue that forms around the tubing. Sometimes fluid builds up acutely right around the catheter tip in the abdomen, that's acute ascites. Or the body can wall off the fluid around the tip, forming a CSF pseudocyst. And like those vagabond catheters, the tubing can perforate the bowel. Or if a piece of tubing breaks off and is left behind, that fragment could potentially cause a perforation later on. There were images showing some of these sites, bowel perforation.
So it's not just the brain end, it's the whole system and how the body interacts with it.
Hmm?
What about those specific syndromes the sources mentioned, like craniostenosis?
Right. Craniostenosis is when the skull bones fuse prematurely. It can sometimes be the cause of hydrocephalus that needs shunting in an infant. Or, potentially, it can develop after shunting in some infants, perhaps as the brain pressure normalizes and skull growth patterns change.
And sunken skin flap syndrome. That sounds traumatic.
It can be. This happens sometimes after a patient has had a large piece of their skull bone removed, maybe for trauma or another surgery, and then they have a shunt placed. With the CSF pressure lowered by the shunt and no rigid skull bone there, the overlying skin and even the brain underneath can sink inwards quite noticeably. This can cause what's called paradoxical herniation, where brain structures shift upwards due to the low pressure and symptoms like headaches that get worse when upright.
Okay. And trapped or isolated ventricles.
This is when, after shunting, most of the ventricles decrease in size as expected, but one ventricle stays enlarged or even gets bigger. It usually means the pathway connecting that ventricle to the others has become blocked off somehow, trapping the fluid inside it.
What about double ventricle syndrome?
This is a specific, rare situation. It typically happens after placing a shunt for a blockage in the aqueduct, which connects the upper ventricles to the lower fourth ventricle. The shunt works well for the upper ventricles, they get smaller. But then the fourth ventricle, down near the brainstem, starts to progressively enlarge. This can cause new problems by pressing on surrounding structures.
Yep.
It often needs its own separate shunt. One of the figures showed this progression clearly over time.
And lastly, slit lateral ventricle syndrome.
SLVS, yeah. This is often seen more in children, but can occur in adults too. It's thought to be related to the shunt draining CSF too efficiently, causing the large lateral ventricles to collapse down into very narrow, slit-like shapes on imaging. Patients often get symptoms of overdrainage, like severe headaches that come and go. It can be quite difficult to manage. The sources mention an adult case treated with a special anti-siphon device on the shunt to try and prevent that excessive drainage.
Hearing this whole range of potential issues, obstructions, infections, migrations, structural changes, these specific syndromes, it really drives home that living with a shunt isn't just a one-off surgery. It requires, well, constant awareness.
Absolutely. That's why lifelong monitoring and regular medical follow-up are so incredibly important for people with shunts. Patients themselves and their families really need to be educated about the warning signs of a shunt malfunction or an infection so they can seek help quickly if something seems wrong.
And it sounds like it often takes a whole team of specialists.
Definitely. The sources really stress the value of a multidisciplinary approach. You've got the neurosurgeons managing the shunt itself, neurologists looking at overall brain function, maybe rehabilitation specialists, ophthalmologists checking vision, pediatricians for kids. Especially important is that transition as children with shunts grow into adulthood and need to move to adult healthcare providers. That coordination is key.
Yeah, that makes a lot of sense.
And, despite all these potential challenges we've discussed, and the real possibility of needing multiple surgeries over a lifetime, it's crucial to remember this too. With the right treatment, with careful monitoring and management, many people with hydrocephalus successfully navigate these complexities. They can lead full, productive lives, often with few limitations.
That's a really important point to end on for the management aspect. So this deep dive looks in these sources. It really paints a picture of this incredible balancing act, doesn't it? Treating hydrocephalus with shunts is this powerful, often truly life-saving technology. It's changed outcomes dramatically. But as we've just heard, putting this piece of essentially plumbing inside the incredibly complex environment of the human body brings this whole host of potential complications, some common, some rare, some just plain bizarre, like those vagabond catheters or the armored brain phenomenon.
Yeah, and understanding that full spectrum of possibilities, which we've tried to lay out based on the sources provided, is just fundamental. It's key for doctors managing the condition and for patients and families living with it long term. It helps everyone know what to look out for and aim for the best possible quality of life.
It really does, and it certainly leaves you with a final thought, doesn't it? Considering this long-term reliance on what is still a mechanical device and all the potential for complications and revisions we've talked about, what might the future hold? Could we see innovations that maybe lead to drastically longer-lasting shunts, or perhaps even biological or pharmacological approaches that could manage CSF dynamics differently, reducing or maybe even eliminating the need for so many surgeries over a lifetime? It's definitely something to think about.